Good afternoon, students. Today's topic is mechanics of breathing, second part. So, in continuation with the previous class, we will see some of the important concepts in the mechanics of breathing. So, in the previous class, you have seen that lungs expand during inspiration and come back to the normal position during expiration. So, because of this inspiration and expiration, the normal respiratory rate or pattern is taking place. So, what are the factors responsible for this inspiration and expiration? So, one is elasticity or the elastic property of the lungs, and one more important property is surface tension. Okay, so the surface tension. So surface tension is due to intermolecular attractions between the water molecules. That is, the water molecules come closer. And the water molecules in the deeper layer are attracted from all sides equally, but not from the surface. So the surface is having air. So in the deeper layer of the water, the molecules are attracted from all sides equally, but not from the surface. So the water molecules do not interact with air molecules. So that is the main reason for production of surface tension. Water molecules tend to shrink to bottom, and this causes collapse of the alveoli and air moves out. Okay. So if they understand this line, so you can easily understand the concept of whole surface tension. Water molecules tend to shrink. Why? Because they attract each other. They come closer. Okay, so in the first line you can see due to intermolecular attractions between the water molecules. So the deeper layers start attracting the water molecules between each other. So they will be shrinking to the bottom, and this causes the collapse of alveoli, and air present in the alveoli moves out. So this is the picture you can see. This is the air layer. So the water molecules do not interact with the air molecules. So the equal interactions are present between the water molecules, which causes shrinking of this water layer. So the alveoli will collapse, and the air present in the alveolar sac will escape out. So surface tension is the force exerted by water molecules on the surface of lung tissue as those water molecules pull together. Okay, it is the force exerted by water molecules on the surface of lung tissue as those water molecules pull together. When the water surface is attempting to contract, it tends to force air out of the alveoli and cause the collapse of alveoli. And if we see the Laplace law, which states that P is equal to 2T by R, that is P is collapsing pressure, T is surface tension, and R is radius. So when the surface tension increases, the collapsing pressure increases and alveoli will collapse. So when the surface tension increases, the collapsing pressure also increases. So the alveoli will collapse. When the surface tension decreases, the collapsing pressure will decrease and alveoli will not collapse. So as we have seen, when the surface tension increases, the lungs or the alveoli will collapse. So what happens if the alveoli collapse? So when the alveoli collapse, it pulls the water in blood like a vacuum. Okay, so from the blood, that is the pulmonary capillaries, the water will be pulled into the alveoli. So that leads to the disease or the pathology pulmonary edema. So in this pulmonary edema, there will be thickness of the respiratory membrane increased. So the respiratory membrane is consisting of 5-6 layers, that is starting from the inwards of the alveolar sac till the blood capillary endothelium. So that thickness will be increased. So because of this increased thickness, the exchange of gases will become difficult. So if we see the effect of radius on collapsing pressure, so for this, imagine two alveoli which are placed adjacently, and the first alveoli is not ventilated well due to the block. So that leads to underventilated alveoli, and which again leads to decrease in the radius of the alveoli. So if the radius is decreased, the pressure increases because of inversely related, and the alveoli will collapse. Because the collapsing pressure increases, surface tension increases, the alveoli will be collapsed. So when the first alveoli is not ventilated, again imagining two alveoli adjacently, When the first alveoli is not well ventilated, the air is diverted to second alveoli, which is well ventilated. Now second alveoli is hyperventilated, which leads to increase in radius and decrease in collapsing pressure. So if the collapsing pressure decreases, automatically the surface tension also decreases, and which leads to alveoli, well ventilation of the alveoli. So the protective mechanisms which are present in the lungs to prevent the alveolar collapse are uh, the pores of Kohn between alveoli. So these are the interalveolar pores. Okay, directly the pores will allow exchange of gases. Air can move from one alveoli to other, which prevents the collapse of alveoli. So these are the main protective mechanism to prevent the alveolar collapse. And coming to the surfactant, it is a surface agent that can greatly reduce the surface tension of water. So the surfactant is a surface agent that can greatly reduce the surface tension of water. So this is produced from the type 2 alveolar cells, alveolar epithelial cells, which are cuboid in shape from the lung epithelial cells. Okay, so in the lung there are type 2 alveolar epithelial cells which are cuboidal shape. So that will produce the surfactant. So the composition of this surfactant is phospholipid, apoprotein, albumin, IgA and ions, 90% lipids. Okay, so phospholipids, apoproteins, albumin, IgA, immunoglobulin A and ions. The most important component is dipalmitoyl phosphatidylcholine, DPPC, and surfactant apoproteins and calcium ions, which will act as a spreading agent. So remember this term DPPC, dipalmitoyl phosphatidylcholine, which is the important component of surfactant. So apoproteins are the surfactant proteins A, B, C, D. And the production of surfactant begins in the 24th week of gestation. It is a slow process which continues till 34th week. And from 34th week, the production of cortisol increases, that is glucocorticoid. So this cortisol stimulates the production of surfactant. So the process will speed up from the 34th week onwards. Okay, so you have to remember this also, which is very important. It will come as a MCQ. Okay, it begins in 24th and progresses till 34th, and from 34th onwards the process will be speeding up because of the production of cortisol. So this surfactant, how it is formed? It is by special type of membrane bound organelles which are present in the type 2 alveolar cells, that are laminar bodies. So these laminar bodies consist of surfactant proteins and phospholipids. These materials are synthesized in endoplasmic reticulum and stored in the laminar bodies. So these are released to the surface by exocytosis. Okay, so the materials which are synthesized in ER and stored in the laminar bodies are released into to the surface of the alveoli by exocytosis. On the surface, in presence of surfactant proteins and calcium ions, they will be arranged in a meshwork, that is tubular myelin, which in turn converts into surfactant and spreads the surfactant layer. Okay, so that is the mechanism of formation of surfactant. So in this picture you can see this formation of surfactant. So these are the type 2 epithelial cells. So type 2 epithelial cells which is synthesizing the endoplasmic reticulum, synthesized. And these materials are transferred to the lamellar bodies, and these are released into the surface by this exocytosis process. So this is the tubular myelin which is arranged in the meshwork form. Okay, so endocytosis and recycling or destruction of surfactant components. So this is arranged in this surfactant manner. So what happens is surfactant, because of attraction between the water molecules, so there will be it will be pulling down so that the alveoli will collapse and the air will be forced out of the alveoli. So this is also one more picture. You can see ER and the lamellar bodies which are releasing the surfactant by exocytosis and spreading like a meshwork, tubular myelin. So important component of surfactant is DPPC, dipalmityl phosphatidylcholine. So this is also one more picture, type 2 alveolar cell releasing the surfactant spreading along the alveolar surface. And mechanism of action of the surfactant. It has hydrophilic and hydrophobic components. Hydrophilic component interacts with water molecule and pulls the layer of water up due to surface tension. Layer of water tries to shrink. So this decreases the surface tension. And the radius of alveoli is small without surfactant because of the Laplace law. P is equal to 2T by R. If the radius decreases, pressure will increase and the collapsing pressure will increase, leading to increased surface tension. And if the radius of alveoli in presence of surfactant, so the distribution of surfactant will be more and surface tension will be decreased, collapsing pressure will be decreased. So the surfactant function is it reduces the surface tension and prevents collapsing tendency of the alveoli. And it is responsible for stabilization of alveoli and it decreases the work of breathing, and it is mainly responsible for a defense mechanism, that is SPA and SPD destroy the bacteria and virus by means of opsonization. So SPA and SPD are surfactant proteins A and D, so which I have told you in the composition of the surfactant. Okay, so these are the important functions of the surfactant: reducing the surface tension to prevent the alveolar collapsing tendency, and stabilization of alveoli and decreasing the work of breathing, and defense mechanism. Factors increasing surfactant production is by vagal stimulation or parasympathetic stimulation, and thyroid hormone and glucocorticoids. And factors decreasing the surfactant production are smoking, hypoxia, and excess of insulin. And coming to the applied aspect related to the surface tension, so that is called infant respiratory distress syndrome. Okay, IRDS. Okay, infant respiratory distress syndrome or hyaline membrane disease also other synonym. If the baby is born before 34th week, the surfactant production is not complete. So we have seen no, it starts from 24th week, but after 34th week only, because of cortisol, the full production of surfactant will be increased and completed. So if the baby is born before 34th week, the production is not complete and the amount of surfactant which is available is very less. So more surface tension is present in the alveoli, leading to alveolar collapse, and this needs the mechanical ventilation for the born baby. So their lungs have extreme tendency to collapse. So that is why it is called infant respiratory distress syndrome. It is fatal if not treated with strong measures, especially properly applied continuous positive pressure breathing. So CPP, continuous positive pressure breathing, if it is applied properly, then only there is a chance of baby surviving. Otherwise, it is a fatal disease. And next, coming to the one more important concept after the surface tension, it is called work of breathing. So work of breathing is the work done by respiratory muscles during breathing to overcome the resistance in thorax and respiratory tract. Okay, so the work done by the respiratory muscles during breathing. Okay, so you know the respiratory muscles which are diaphragm and then intercostal muscles. Okay, so the work done by those muscles during breathing to overcome the resistance in thorax and also respiratory tract. So that is nothing but work of breathing. So during the respiratory process, inspiration is active and expiration is passive process. So during quiet breathing, respiratory muscles perform work only during inspiration and not during expiration, because expiration is a passive. So work is done only during the active process, that is inspiration. During quiet inspiration, 65% of work of breathing is to overcome elastic recoil tendency of lungs, and this is called the elastic work or compliance work. So lungs always tend to shorten back or fall back. So 28% of work of breathing is to overcome the airway resistance. So medium and large sized airways offer most of the airway resistance and not the smallest, that is terminal bronchioles. So 7% of work of breathing is to overcome the tissue resistance. So these are the categories, percentage wise division of work of breathing. 65% to overcome the elastic recoil tendency, that is the highest amount, and remaining 28% is to overcome the airway resistance, and the least 7% is to overcome the tissue resistance. So in certain diseases, there is increased work of breathing, and depending upon the nature of breath, there will be specific increase in work of breathing. So like in asthma, there is increase in work of breathing to overcome the airway resistance. And whereas in restrictive lung disease, there is increased work of breathing in both overcoming both tissue resistance and also elastic recoil. So what are these diseases and why specifically in asthma there is airway resistance more, and restrictive lung diseases why there is tissue resistance and elastic recoil, we will see in the coming classes. So as we know, the gas flow in a pipe or a tube is equal to pressure difference between the two ends divided by the resistance. Okay, so this is delta P is difference in pressure and R is resistance. So this is the nothing but airway resistance. So we can rewrite as R is equal to pressure difference divided by gas flow, okay, or air flow. So the pressure difference here will be the difference between the atmospheric and alveolar pressure. So difference in pressure is directly proportional to the gas flow, and increase in the pressure will increase the gas flow provided resistance is constant. So for understanding this gas flow, you imagine there are 4 alveoli with different pressures like mentioned here. You know that atmospheric pressure is 760, and the first alveoli is same as atmospheric, and second alveoli it is lesser 754, and third little more lesser 730, and fourth is 1 mmHg higher. So the pressure in first alveoli is equal to atmospheric pressure, so net flow is 0. And second alveoli it is slightly lower, so the moderate airflow will be present. And third, it is little more lower, so there will be maximal airflow. And in fourth, it is higher than atmospheric, there will be reverse airflow, that is from alveoli to the atmosphere. And the resistance offered to the air in respiratory passages is the airway resistance. High resistance is present in larger bronchi and bronchioles, and low resistance is present in the minute terminal bronchioles, and the number of minute parallel terminal bronchioles are high, very high, that is 65,000. So the source of resistance in airways is produced by the friction. Okay, so this is the source of resistance in airways. So resistance is very low in respiratory passages. So it is because of terminal bronchioles where there are very high in number, the cross section area is large, so there will be very low resistance. So this airway resistance is measured by instrument body plethysmography. So why the airway resistance is low in the respiratory passages? So there are 3 reasons. Most of the passages of conducting zone has large diameter. So conducting zone, you all know the first part. Okay, so nose to bronchi, first primary bronchi, and there are so many divisions after that, and bronchioles are many. So total cross-sectional area of bronchioles is very high. So in the respiratory bronchioles, the gas flow stops. Okay, so actually there will be diffusion. Diffusion process will take over, and the gas flow will stop in the respiratory bronchioles. That is the terminal bronchioles. That is why the resistance is very less in this terminal bronchioles or respiratory zone. So if we see in asthma, the airways will be constricted. So in asthma, the airways will be constricted. So there will be decrease the diameter of airways. There will be increased friction. If the diameter is decreased, friction will increase, and this will cause more resistance. The patient has to put lot more effort into breathing to maintain air intake adequately. The turbulent flow is present within the airways, and which causes wheeze of the asthma attack. Turbulent flow means, so the laminar flow, straight line flow is converted to turbulent, that is wavy, irregular pattern of flow will be present. So that is the cause of wheeze for asthma attack. So you will be understanding slowly these terms in the coming classes. And next we move on to the concept of compliance. So this is also very important concept. So we have seen till now the surface tension and work of breathing. In the work of breathing, the reason is airway resistance, that also we have seen, and the concept of compliance. So in this we will see the compliance and elasticity and also the factors affecting compliance. So the definition of lung compliance is the change in volume of the lungs per unit change in transpulmonary pressure. So pressure difference between intrapleural and intraalveolar pressure. So the normal value is 130 ml per centimeter of H2O for lungs and chest wall together, and normal value 200 ml per centimeter of water for lungs alone. Okay, so this is for both lungs and chest wall. This is only for lungs. So lung compliance graph. When it is plotted in the form of graph for inspiratory and expiratory phases, the curves will not overlap but bring about the formation of hysteresis loop. So it is due to a change in elastic property of lungs and chest wall. The slope of straight line is equal to delta y by delta x, nothing but delta v by delta p is equal to compliance. So difference in pressure, volume by difference in pressure. So this is the picture of lung compliance. So the graph for inhalation and the curve for exhalation will not be combined, and they will form a hysteresis loop. Okay, so this is a loop. So this on the y-axis we have lung volume, and on x-axis we have pleural pressure. So static compliance, this compliance is of two types, static and dynamic. Static compliance is defined as change in lung volume per unit change in pressure in the absence of flow. It is composed of chest wall and lung tissue compliance. And dynamic compliance is defined as change in lung volume per unit change in pressure in presence of flow. So it is composed of chest wall compliance, lung tissue compliance, and airway resistance. So how to measure this compliance? So we ask the subject to inspire and expire in short steps of 50 to 100 ml. In this way we measure the transpulmonary pressure. So transpulmonary is equal to alveolar minus pleural pressure. When alveolar pressure becomes 0, that is when the subject is not inspiring or expiring, alveolar pressure is also 0. So transpulmonary pressure becomes equal to the pleural pressure. We can measure this by esophageal method. If you remove one lung, the compliance becomes half of the normal value. Okay, so the transpulmonary pressure will be equal to the pleural pressure, which can be measured by the esophageal method. So measures compliance and elasticity, both are the measures of ability to stretch lungs and the chest wall. The ease to stretch is called compliance, and opposite to compliance is called elasticity. And elasticity tries to recoil the lungs, that is both lungs and chest wall. So compliance is equal to delta V by delta P, and elasticity is equal to delta P by delta V. So you know that delta V is change in volume and delta P is change in pressure, transpulmonary pressure in case of lungs and transthoracic pressure in case of chest wall. So the compliance is directly proportional to change in volume and inversely proportional to change in pressure, and elasticity is exactly opposite to that. And the factors affecting compliance are three factors. One is elasticity of the lungs and chest wall, and then surface tension. So the first one, elasticity of the lungs. Lungs are very compliant, that is they can expand with ease. So at the same time they can recoil also, that is elasticity. So normally both are equal, but if you think for one moment, if you think the lungs becomes more elastic, what happens? They will be trying to recoil more, that is even with small expansion they will easily again coming back to normal position. There will be always collapsing of the lungs. So elasticity is inversely proportional to volume. Volume in lungs will decrease if elasticity increases. So in case of pulmonary fibrosis, which is a lung disease, there will be a lot of fibrous tissue all over the lung. So you all know the fibrous tissue. It consists of fibroblasts and extracellular matrix containing the fibrillary structures, that is collagen and elastin. So elastin is the main component of elastic fibers. So in this fibrosis, what happens? The content of the elastin increases. So lungs are not able to stretch because of decreased compliance. Because the normal tissue is not present, it is replaced by fibrous tissue. So and also the elasticity increases because of increased elastin. So elasticity, as we know, it inversely proportional to volume. So the volume will be decreased in the lungs in case of pulmonary fibrosis. And in case of emphysema, lung is super compliant, that is compliance increases. There will be loss of elastic tissue. Compliance increases, elasticity decreases. Elasticity is inversely proportional to volume, so the volume increases. Okay, easy to take in air but not easy to move the air out or send the air out because of decreased elasticity. So this is emphysema. So one is pulmonary fibrosis where the elasticity increases, and emphysema is another condition where the elasticity decreases. So the chest wall elasticity, normally compliance and elasticity are equal, but in diseases like kyphosis and scoliosis, that is a shaped spine, ankylosing spondylosis, lungs cannot expand. So restrictive respiratory disorders also, there will be uh, expansion of the lungs will be difficult, and compliance decreases. They have very difficult to breathe. Breathing is very hard, and inspiration is also that is same. Both are same. Inspiration is difficult and hard to breathe in. And one more factor affecting compliance is surface tension. So increase in surface tension is seen in IRDS, and all the alveoli will collapse, lung will collapse, and the compliance decreases. Lot of resistance to stretch. For stretching, there will be a lot of resistance present. Hard to breathing and increase in work of breathing. If surfactant is present, it decreases the surface tension, so the lungs can expand with ease. That is, compliance increases and work of breathing decreases. So that is the reason why surfactant has to be present for the normal compliance. Pneumothorax and hemothorax. So these are the pneumo means air. Air in the pleural cavity is called pneumothorax, and blood in the pleural cavity is called hemothorax. So intrapleural pressure becomes same as the atmospheric pressure when there is in these conditions. So positive intrapleural pressure, which will start pushing the lungs. There will be collapse of the lungs and compliance decreases, volume decreases. So these are the other applied aspects. And lastly, we'll see the slide which shows the increase and decrease compliance. So increase in compliance is seen in physiological conditions, old age due to loss of elastic property of lungs, and pathological condition, emphysema. It is the only condition in which there is loss of membrane and loss of elastic tissue. And the decrease in compliance is seen when there is in these conditions. So decreased compliance means lungs are difficult to expand. So it is seen in fibrosis, atelectasis, COPD, chronic obstructive pulmonary disease, and effusion, bony deformities like kyphosis, scoliosis, and surfactant deficiency and respiratory muscle weakness. So in these conditions, there will be decreased compliance. Okay, so that's all for today's class. I hope you understood. So these three are very important questions: alveolar surface tension, airway resistance, and lung compliance. So write down all these three as an assignment in your notebook and send to me. Okay, so thank you all.